So let's go ahead and get started. For strategies to maximize clients' effective use of FDA-approved pharmacotherapy, our presenter today is Dr. Christine Garver-Apgar, the Behavioral Health and Wellness Program's Research Director. Thanks very much and enjoy today's presentation. Christine.
Hi, everybody. Thanks, Amy. So I just want to start out by thanking everybody for taking the time today to attend this webinar. I know everybody's got lots on their mind this past week, and so everybody's really busy. Anybody in a position to serve people are just feeling extraordinarily busy. So I just really appreciate taking the time to make today's webinar. I have no conflicts of interest to disclose. So this is a webinar about medication-assisted therapy, but I'm not going to spend a whole lot of time introducing all of the specific tobacco cessation medications in great detail. Instead, I'm going to try to move beyond basic knowledge of tobacco cessation medications and discuss how to really maximize pharmacotherapy's effectiveness. If you do need basic information about all of the FDA-approved pharmacotherapies for tobacco cessation, please see this link that's listed here. And this will take you to a video of another webinar that I conducted. Some of the information will overlap with what I'm presenting today, but much of it offers really more of an introduction to pharmacotherapy. So if you do need that information, please visit this link. So this is the agenda for this hour. In the first section, I will describe critical things that both clinicians and clients should know about nicotine addiction, cravings, and withdrawal in order to maximize their use of cessation medications. In the second part of today's webinar, I'll discuss ways that clinicians can better prepare their clients to make a quit attempt with the help of cessation medications through education and discussions about assessment and proper dosing, how to use medications, and strategies to increase medication adherence. And then also information about preventing relapse, but also addressing it when it occurs. So that's where we're headed. We'll start out by talking a little bit about nicotine addiction and why cessation medications are helpful. Not because anybody attending this webinar needs convincing that nicotine is an addictive drug, but because sometimes our clients aren't really thinking about the physical addiction to nicotine. And so having this discussion with some clients can be a powerful way to dispel the myth of willpower as being something lacking in someone who hasn't yet had success quitting tobacco. It's also important that clients understand nicotine addiction so they can develop proper expectations about what tobacco cessation medications will and will not help with, and why medications themselves are not addictive. Individuals with addictions to other substances like alcohol, heroin, or cocaine will very often report that tobacco was the most difficult addiction for them to overcome. So it's no surprise that more people who try nicotine become daily users than those who try other drugs. So why is it that nicotine is such an addictive drug? Well, part of the reason is that tobacco companies have spent many, many decades now perfecting how to get nicotine to the brain as fast as possible. Because the faster it gets there, the faster an individual experiences that behavioral reinforcement from smoking, and the more addictive it becomes. Each cigarette, we know, delivers about 1 to 2 milligrams of nicotine. And this is going to be important to know when we start talking about dosing nicotine replacement therapy a bit later. After a person takes a puff from a cigarette, nicotine from that inhalation will reach the brain within 10 seconds. That's even faster than if you had injected nicotine intravenously. Because it reaches the brain so fast, smokers can very easily control how much nicotine they get, and that makes cigarette smoking more reinforcing than nicotine obtained any other way. And that's also why nicotine from other sources, like the nicotine patch and the gum have a much, much lower potential for abuse. This slide summarizes abstinence rates for different treatment strategies, starting with no treatment at all. Clinicians can help clients understand that unaided quit attempts are not often successful, and that this doesn't indicate a problem with willpower for the reasons we've been talking about. While all of these techniques are effective compared to no treatment, you can see here that a much higher percentage of people who receive medication and counseling are able to quit using tobacco compared to no treatment at all. Clients should understand that the reason that counseling and medication together are the most effective at treating tobacco dependence is because tobacco dependence has two different parts. Pharmacotherapy addresses the first part of tobacco dependence, which is the physical addiction to nicotine, whereas counseling addresses the second part of tobacco dependence, which is the habit or the behaviors surrounding tobacco use. It's really important for clients to have realistic expectations about how tobacco medications are likely to help. They're likely to help with physical craving for nicotine, but they don't replace counseling to change behavioral habits. Okay, this slide lists the 7 medications that have been approved by the FDA for smoking cessation. I'm not going to go over these in great detail. 5 of these contain nicotine. They're called nicotine replacement therapies, or NRT, and 2 of them do not contain nicotine. 3 of the NRT medications are available without a prescription. That would be the nicotine patch, the gum, and the lozenge, whereas the remaining medications all require a prescription. These are all effective medications, as you'll see on the next slide. So the best one to use is really the one that patients will use and will use as directed. So this is a slide that is summarizing a very large review of clinical trials looking at the efficacy of behavioral and pharmacological interventions. This chart reviews results from several different meta-analyses in which data from multiple studies are pooled together for analysis. NRT, bupropion, and varenicline all improve the chances of smoking cessation at 6 months follow-up or longer compared to a placebo. And that's what this is showing. NRT and bupropion increase the likelihood that a person will be abstinent from tobacco at 6 months post-quit by about 60%. Varenicline, on the other hand, more than doubles the likelihood of abstinence at 6 months compared to a placebo. And that's what those numbers are indicating, the estimated risk ratio. This slide provides a snapshot of quit rates maintained over 3 years across all of these FDA-approved medications. And the take-home message here is simply that the quit rates for individuals who use some form of cessation medication, no matter which one they use, are higher than for those individuals who just use a placebo. So again, it doesn't so much matter which medication a person uses. The most important take-home message that we want to emphasize is that the most effective one is the one that clients will use. Nicotine addiction is no different from any other addiction. People use addictive substances because there are rewards from using them. And today we're talking about biological rewards like feelings of arousal and pleasure. All drug addictions involve physical dependence, which means experiencing both tolerance to a drug and also withdrawal. So as tobacco users become tolerant, they must increase nicotine use, either to get the same biological rewards or to simply avoid symptoms of withdrawal, which then of course leads to craving and ever greater addiction. When people stop using tobacco products, and depending on their level of use, they will very likely experience some or all of the symptoms shown here. And usually they will also experience a strong desire or a craving for tobacco. They can also experience symptoms of depression because taking away nicotine has the effect of reducing dopamine and serotonin activity in the brain. In general, withdrawal symptoms appear within the first 1 to 2 days. They peak within the first week, and then they gradually diminish over the next 2 to 4 weeks. But we know that cravings and urges for cigarettes can take much, much longer, even months or years, to go away after somebody quits. Cessation counseling helps to address the behaviors or the habits surrounding tobacco use. But we know that when someone is experiencing symptoms of physical withdrawal, counseling is not particularly effective, which is why pharmacotherapy in combination with counseling can be so helpful. Cessation medications work by helping to alleviate nicotine withdrawal so that people can focus on working to change their smoking behavior. And that's an important message for clients, that the medication can be really helpful, but it often isn't the entire solution. So I just want to spend a couple of minutes going through this nicotine addiction cycle because it speaks to the type of nicotine replacement therapy that a person might be interested in using. So what this chart is showing is the typical nicotine addiction cycle of a cigarette smoker experienced on a daily basis. This is a hypothetical graph. The jagged line here represents the plasma concentrations of nicotine as a cigarette is smoked every 40 minutes it's showing from 8 a.m. until 9 p.m. The upper solid line shows the threshold concentration for nicotine to produce pleasure or arousal. So everything above that shaded area would indicate that a person is feeling really good. Below the shaded area indicates a plasma concentration where people would start feeling kind of lousy. They might start feeling symptoms of withdrawal. And then the shaded area just represents that those concentrations where a person feels fine. They don't feel particularly great and they don't feel poorly either. And what I want you to notice about this figure is the arousal or the pleasure that people experience after smoking that very first cigarette of the day, all the way down at 8 a.m. You'll notice that nowhere else on this addiction curve do you see the jagged line go so high above that comfort zone and into the pleasure zone. This is why many smokers will say that their most important cigarette is the first one of the day. And how quickly someone smokes that first cigarette is an indicator of tobacco dependence, as we'll be seeing in just a couple minutes. The reason that first cigarette is the most pleasurable one is because tolerance starts to develop very shortly after that first cigarette. And as smokers become more tolerant to nicotine throughout the day, they get less and less pleasure out of each cigarette. So instead, by, it looks like on this graph around 6 o'clock or so, the person is smoking just to avoid feeling nicotine withdrawal effects. They're not really getting any pleasure anymore. They're just smoking so that they don't feel lousy. Overnight, a smoker becomes resensitized to nicotine, and then that cycle starts all over again the next day. This figure also explains why you would commonly hear in trainings, including this one, that a common recommendation is to take a gum or a lozenge immediately upon waking to boost that steady nicotine that's been being offered in a patch if somebody is using the patch. But the medication does take 15 to 20 minutes to work, so clients won't experience an immediate sense of relief with that strategy, and it's really important that clients realize this. Okay, so in this second part of the webinar, I'm going to continue the theme of how to better prepare clients to make a quit attempt using tobacco cessation medications. I'm going to cover how to administer a validated assessment of nicotine dependence, and then some key tips and tricks that are important to know when using particular medications, especially NRT. And then I'll also talk about strategies to help clients and clinics with medication adherence, and how to help clients prepare for relapses when and if they happen. So one of the best ways that clinicians and providers can help prepare clients for an effective quit attempt using medications is to start off with the right dose. To do this, it is a very good idea to use a validated assessment tool as a starting point for dosing NRT. The two prescription medications that don't contain nicotine have more regimented, standardized dosages, so I'm only going to talk about nicotine replacement medications here. The Fagerstrom test for nicotine dependence assesses a person's physical dependence on nicotine. It has 6 questions shown here, and it is validated for adults. There's also a version for adolescents called the MFT-ND. The two items in this rectangle shown here together make up the heaviness of smoking index. The reliability of the heaviness of smoking index, or the HSI, in other words, just the two items that are in the rectangle, it's comparable to the Fagerstrom test, although there is some evidence that suggests that if a person is not highly dependent on nicotine, then the full 6-item measure might be preferable in that instance. But both assessments are short, especially this 2-item version, and they can both be adopted into current workflows without a whole lot of effort. So, and they're both very, very easy to score. You just would add up the points as shown here. So this chart serves as a rough dosing guide that corresponds to the scores on these two assessments. Scores on the full measure range from 0 to 10, with 10 being highly physically dependent on nicotine. And scores on the heaviness of smoking index range from 0 to 6, with 6 being highly dependent. So from a clinic management point of view, adopting one of these tools into workflows provides the clinic another way to evaluate whether patients are being delivered quality evidence-based care. So it would help a clinic to know whether clients who use tobacco are having their dependence assessed, and then if they are they being recommended or prescribed the baseline level of NRT that they should be. I also wanted to provide a link to a quick reference tool that we created, which summarizes the FDA-approved medications, the assessments that I've talked about, dosages, and dosing schedules. So you can find that here at this link. So just a few other points that I want to make about dosage. When a provider talks to a client about dosage, they should communicate that they've gotten a dosage recommendation from a tool, and that the tool provides a conservative dosage. And unless the provider has other reasons to expect that the client needs more, this recommendation is a good place to start. However, clinicians should know that nicotine is frequently underdosed, and this can be for a variety of reasons. For one thing, each cigarette delivers anywhere from 1 to 2 milligrams of nicotine, which I mentioned earlier. That's actually a pretty large range. And the initial dosage, based in part on how many cigarettes people smoke per day, it seems to assume the lower level of nicotine absorbed per cigarette. And that just isn't true for everyone. So I want to just go through a quick example using our assessment tools just to illustrate this. So here's the Fagerstrom test again. If we look at just these top 2 questions, let's say that a person selects 5 to 30 minutes upon waking for question number 1, that's how soon they smoke their first cigarette. So that would earn them 2 points for question 1. And for the other question, number 4, let's say that the person says they smoke 1 entire pack of cigarettes per day. That would be 20 cigarettes. So they would get 1 more point for question number 4. Now that would give this person a total score of 3 on the heaviness of smoking index. If we look again at our chart, a total score of 3 on the HSI corresponds with low to moderate physical dependence on nicotine. and a correspondingly relatively low dose for the patch. The recommendation would be 14 milligrams to start. But in this case, a person could very well be underdosed, especially if they're a person that tends to take in closer to 2 milligrams of nicotine per cigarette. So this is just something to be aware of, that these tools provide a good place to start, but they're not set in stone. These should be thought of as guidelines. There's also a lot of individual variation in terms of how quickly a person metabolizes nicotine. That can also impact physical dependence. And moreover, many people underestimate how much they're smoking. So for all these reasons, many people will find that the initial recommendation for NRT dosage that they were given is just not effective for them. And both clinicians and clients need to know that it is very difficult to overdose on nicotine. People who are taking too much nicotine will start to feel really lousy long before they would experience any significant long-term consequences of too much nicotine. So if a client is taking NRT as they've been ordered, and they're still having high levels of cravings, they shouldn't hesitate to either increase the dose themselves or to make another appointment to talk with a provider about increasing their dose. So there are several strategies for using FDA-approved cessation medications that both providers and clients themselves should know about. Research has found that cessation rates are actually higher when individuals use a combination of these NRT medications rather than just one at a time. Actually, I should say a combination of medications, not just NRT medications. So in 2008, the clinical practice guideline recommendations were updated to include any combination of NRT. So it's considered safe to use the patch along with any other form of NRT. And then it's also considered safe to use bupropion with either the patch, the gum, or the lozenge. And so all of the combination therapy recommendations that are approved by the FDA are shown here in this slide. Another strategy to increase the efficacy of NRT is to start using it before the quit date. Providers have started using nicotine replacement therapies before an individual actually makes their quit attempt, and results from studies so far seem to show that there are no increased side effects from doing this. And increased efficacy. So for example, one study showed that using the patch prior to a quit date could double, in this case, for this particular study, the success rate of that particular quit attempt compared with using the patch starting on the quit date. So that's just something to be aware of. Oops. So which medication is best? The best is still the medication that clients will adhere to and take as directed. And personal characteristics of clients will really determine which medication they're interested in taking. But one common finding in the medication adherence literature is that the more complicated a treatment plan is in general, the less likely it is to be followed with fidelity. So in general, fewer doses per day is better in terms of medication adherence. So for tobacco cessation medications, what this implies is that the patch would be the best option, followed by varenicline and then bupropion, and then the gum or the lozenge. A traditional gum or lozenge regimen would be for the client to take 12 regularly spaced out doses per day. And then if determined necessary by the dependence level, to then supplement that with the patch. But 12 regularly scheduled doses is pretty hard to follow with any kind of precision. As I mentioned before, though, the problem with giving a conservative amount of nicotine through the patch and then supplementing with the gum or the lozenge as needed is that the gum or the lozenge can take 20 minutes to address that craving, and the client is vulnerable to lapsing or relapsing in that time. So in keeping with the idea of simplifying the medication regimen, and moving clients toward treatment plans requiring fewer doses, or if a client is having difficulty managing multiple forms of NRT, the client could consider a higher dose of the patch. If they're having lots and lots of breakthrough cravings, you might just need a higher patch dose. But if a client likes the idea of multiple modalities of NRT and they like having something to deal with cravings, they just need to know that these medications don't work immediately. And this is really where counseling comes in. Given that the gum or the lozenge takes a while to work, can you encourage clients to anticipate times of high cravings and then maybe actually take the medication before a craving is likely to begin? Just a few other tips about particular forms of NRT. For the patch, it's really helpful to provide clients with instructions for how to properly do this, because that really does determine its effectiveness. When a patch is not properly applied, it has a tendency to fall off. And additionally, the patch doesn't respond very well. It doesn't withstand water. So that would include sweating with exercise. So clients should really be aware of this. And it is actually really helpful to go through with your clients and demonstrate how to use the patch. Cutting the patch is not effective because the sustained release aspect of the patch is compromised. If it's cut, the medication would leak out too quickly, and then it probably would not be effective for as long as what it should be. So cutting it is definitely not recommended. So there's just some other tips and tricks listed here, but what's important to know is really for any kind of NRT, it's good to really walk clients through using that particular medication instead of just assuming that they're going to read the directions themselves. For the gum or the lozenge, it's important for the clients to know that they're not going to be chewing a piece of gum like they would chew normal pieces of gum. What you want to do is chew until that little tingly feeling arrives, and then you can park the gum between your cheek and your gum. The nicotine is absorbed through the membranes in your mouth. So if a client chews the gum and swallows all the juicy stuff, what's happening is they're just swallowing the nicotine. It's just going to make them nauseous, and it's not going to be very effective. So some people don't know that the nicotine replacement therapy gum isn't like normal gum. So you chew and park, and then when the tingly feeling goes away, you chew it a little bit just to get that feeling back, and then you park it somewhere else in your mouth. And so clients, they really do need to know that. And then as well, clients should avoid acidic drinks like coffee or juice or wine for about 15 minutes before using any of these oral forms of NRT for them to be effective. So there are a few other ways to prepare clients for using cessation medications that involve helping clients set expectations and also become engaged agents of their own tobacco cessation goals. So first, many clients have tried NRT before, and they may have received advice or warnings from friends and family members about these medications. And so part of setting expectations may actually involve exploring with the client what they currently know about NRT and how they came by that knowledge. Because in some cases, clients may not have received accurate information. Another discussion to have with some clients is that it's extremely difficult to become addicted to NRT, unlike other forms of tobacco, especially cigarettes. So for interested or concerned clients, providers can explain about why that is. So what we talked about before, that nicotine from NRT doesn't reach the brain nearly as fast as nicotine through cigarettes, and so it's much less reinforcing. Clients should practice using pharmacotherapy. And some research even suggests that actually sampling different medications improves adherence and cessation. There's also a belief held by both providers and clients that the mode of NRT delivery would be most effective if it matches the client's current mode of using nicotine products. So what that means is if a client is a smoker and uses cigarettes, that would mean that they should use an inhaler as their choice of NRT. If they use snuff, then maybe they should use the nasal spray. Or if they're using chew, then that would mean using gum. But what I want to make clear is that there's really no evidence that this belief is true. So adjusting from one form of NRT to another should not affect the efficacy of the medication, no matter whether a client is smoking cigarettes before or using some other form of a nicotine product. In general, being really flexible with patients and experimenting with what works for individuals and troubleshooting seem to be really important for finding a medication strategy that works and that patients will stick with. Of course, it's also important to acknowledge that allowing clients to experiment for a couple of days or a week with different versions of NRT, that does mean arranging for follow-up with the client so that they can discuss their experience and determine the best treatment plan. There's one other really important thing that both providers and some clients should be prepared for when quitting tobacco. People who are using psychiatric medications require special considerations when they quit smoking. This is because the system that metabolizes many of the toxins and carcinogens in cigarette smoke is the same system that processes psychotropic medications as well as caffeine. And the reason this is important is because tobacco cessation can actually affect the blood level of many different types of medications, including those psychiatric medications. So what happens is, as tobacco users metabolize and excrete nicotine and other chemicals in cigarettes, they're also more quickly metabolizing prescribed medications. So when an individual quits smoking, blood levels of many of those medications can significantly, sometimes dangerously increase. Sometimes side effects of higher dosages of prescribed medication are actually confused with nicotine withdrawal or psychiatric symptoms. And then I just want to mention that tobacco use and cessation have the same effect on caffeine. So individuals who use large amounts of caffeine while they're smoking, they may no longer be able to tolerate these levels when they quit smoking. Individuals could report increased anxiety, for instance, but that could actually be due to the amount of caffeine that they're continuing to use and not necessarily a symptom of nicotine withdrawal. So it's important that prescribing providers are aware that their patients are quitting nicotine or tobacco and that they need to monitor medication levels. But it's also important that clients themselves understand these relationships between smoking cessation and their psychiatric conditions. So this is a list of medications on this chart that are known or suspected to have their levels affected by smoking and smoking cessation. And I just want to mention here that this concern applies really only to tobacco. It is not the case that if a person starts and stops nicotine replacement therapy that they would necessarily have any effects on psychiatric medication blood levels. We think that's because it's metabolizing all the chemicals and carcinogens in tobacco that causes the differences in metabolism and isn't necessarily the nicotine itself. So this is a problem when a person stops smoking, but it isn't a problem when a person stops NRT. Okay, so one of the ways providers can help clients set realistic expectations is to talk about lapses and relapses. A lapse here refers to an isolated use of tobacco, whereas relapse refers to a return to regular tobacco use after a period of abstinence. According to a recent study, the risk for relapse during the first 12 months is over 50%. And relapse prevention really needs to begin at the very beginning, at the initial assessment, not just after a relapse occurs. Initial and follow-up counseling can focus on learning to anticipate and cope with the challenges that often lead to relapse. In particular, with regard to medications, clients and providers need to know that if a client has a lapse or a relapse, they do not need to stop taking their cessation medications. They should continue their medications. And this is often something that clients really worry about when they have those lapses or relapses. So this is a good example of something that should be discussed before the quit date, so that clients know what to do if they have one of those lapses or relapses. Any smoking at all, especially in the first 2 weeks of a quit attempt, will significantly increase the relapse rate. Most relapse we know occurs within the first 3 months of abstinence. And after a year, the risk for relapse decreases more and more every year after that. People who are preparing to stop their tobacco use should remove tobacco and also tobacco-related products from their environment before their quit date. And identifying high-risk situations that could trigger a relapse helps the individual to prepare and plan for how they're going to handle situations when they arise. Individuals can also make changes in their environment to avoid being triggered. As people engage in these types of tobacco-free behaviors or other behaviors that facilitate their well-being, these experiences can really start to increase their confidence that they can live a tobacco-free life. So thinking ahead about situations where triggering events are likely to occur and planning for how they're going to deal with that, that can be a really powerful way of, like I said, increasing a person's confidence even before a quit date. Okay, so other adherence strategies to consider. I just want to mention adherence interventions that involve multiple components are best, but providers should take care not to overcomplicate the treatment plan for the client. Look for strategies that are already aligned with the client's treatment plan. And this slide lists a few things that different sites could consider in some cases. So I'll just highlight a couple of these as examples of how NRT adherence could be attached to other protocols that may already be in place. So for example, if a client has a case manager or an aide that goes to the client's home for the purpose of monitoring, say, a medication for schizophrenia, then that individual could also observe the NRT medications as well. Or if a client is already in family treatment, be sure to communicate to the family therapist that the client could use some additional assistance with NRT adherence, if that's the case. When training behavioral health providers, suggest that relapse plans be a part of treatment plans more broadly. So we've talked about how providers want to avoid making treatment more complicated than is necessary. Medication adherence protocols do complicate the treatment plan for the client, and they add additional oversight tasks for the clinic or the clinician. So we wouldn't necessarily want to add medication adherence protocols to everyone, assuming that everybody needs those additional protocols. So we want to try and identify those people for whom medication adherence might be an issue. So to summarize those 3 bullets in the top banner, higher risk for medication noncompliance. We see for people who take relatively more medications already, so they already have a complicated medication regimen, and then those who need a lot of complex medication treatment. NRT just isn't as good as cigarettes in delivering nicotine. So Higher dependence would also mean that cravings just aren't addressed quite as well. So for people with higher dependence levels, they might be more at risk for medication non-adherence. Whether a person is identified as a higher risk or not, clinicians should still be on the lookout for clients that might not be taking their medications in the most effective way so that they can address those issues. So these signs appear in the second banner. Missed appointments and missed refills might be indications that a client is struggling with their medications. And then finally, clinicians should just simply be asking clients about their use and in their experience to determine if using medication adherence protocols might be necessary. You can use this exploration time to determine what precisely is this particular patient's barrier to compliance, and then try to adjust their plan accordingly. And that is all of the information that I have to provide to you today for this webinar. Amy, I'm going to turn it back over to you now. Amy's going to run our question and answer session.
Great. Thank you, Christine. At this time, we'll open it up for questions. As discussed at the beginning, you can send your questions to us one of three ways. You can use the chat or Q&A buttons at the bottom to type in a question, or you can raise your hand and we will unmute your line.